One of the most important conversations we should be having about our health is one that most women were never taught to have. But the connection between your central nervous system, your strength, your balance, and even your confidence all ties back to something we rarely talk about openly. Research shows that a significant number of women, with some estimates as high as 70%, do not fully understand how to properly engage their pelvic floor muscles or even why keeping them strong matters in the first place. And when it comes to hormones, something that impacts everything from our energy to our health to our brain, many women are making decisions based on fear, not information. In fact, about 65% of women avoid hormone therapy due to the fear of side effects, and over 60% worry it may cause breast cancer or stroke, often based on outdated or incomplete information. Today, we are diving into this topic because it is often overlooked, misunderstood, and yet absolutely essential to how we move, feel, and function every single day. This is not just about one part of the body. This is about how everything is connected, from your central nervous system to your pelvic floor to your hormones, and the role that connection plays in your overall health, especially as we step into our Encore years. There is research showing a connection between lower bone density and an increased risk of cognitive decline, including Alzheimer's disease. This has been on my radar for the past couple of years since my diagnosis with osteoporosis and with my dad having had Alzheimer's. When I hear something like that, my ears perk up. Now, that does not mean one causes the other, but it does suggest that our bone and our brain health may be more connected than we have been led to believe, likely through shared factors such as hormones. Joining me today is Dr. Dani, a research-informed physical therapist and a women's health expert who is passionate about helping women understand their bodies in an empowering, practical way. In this conversation, we are going to break down what every woman needs to know. So, Dr. Dani, how are you? I'm so glad that you're here today.
I'm good. Thank you so much for having me. I'm excited to have this conversation with you. I think it's great information that a lot of women need and just don't have access to.
I'm going to start off with, when most women hear pelvic floor, what are they missing or misunderstanding, and how does the central nervous system play a role in all of this?
Sure. I think a lot of people, now we're starting to talk a little bit more about pelvic floor. You hear it in social media, but I feel like a lot of people think about it just during pregnancy and postpartum. And this idea that when you're pregnant, like we got to do a bunch of Kegels, and then postpartum, we got to do a bunch of Kegels, and that's going to make everything better. But the pelvic floor is with us from the start to the end. And it's important throughout that whole lifespan, and it changes as we age. So yes, pregnancy certainly affects the pelvic floor. Giving birth, whether it's cesarean or vaginally, affects the pelvic floor. But even if you've never been pregnant, never had a baby, you still have effects on the pelvic floor from the pressure that goes through our system on a regular basis. And related to the central nervous system, generally in this society, I find everybody's like functioning like up here stress level. Like we're all just like spazzed out. And I don't know many people I can touch like upper traps that they don't have some tension and tightness there. There's a correlation between the tension that you hold in your shoulders and the tension that is most likely in your pelvic floor. There was a study done a long time ago about watching scary movies, and that when you watch a scary movie, people tend to do this. But with that upper trap tightness, they also found pelvic floor tightness was happening. A lot of people are holding this tension. And I tell my patients, if you just like tune in, are you clenching like for dear life down there, or is everything relaxed and calm? And if we're sitting, really the pelvic floor should be pretty calm. If we are clenched and holding, we're creating extra tension there that we don't need. And as we're aging, the estrogen level, our hormones start to change, right? So we talked about the hormones, and that estrogen affects the brain, the heart, and the muscles, and especially the tissue of the pelvic floor, the vaginal tissue and the labia minora, labia majora. I have my fancy little model here, right? Most of us, we have this idea of pelvic floor is there, but we don't always know what that is. I feel like we're just starting to talk about it a little bit more. But there's a ring of muscles in the bottom of the pelvic floor that attach from pubic bone to tailbone and your two sit bones. And they create this little hammock that carries and holds the pelvic organ. So the bladder, the rectum, and the uterus sit in there. And then it also helps with maintaining continence so that we're not leaking, and helps with sexual function too. So if that estrogen level is changing and this tissue is changing, it can affect all of those areas on top of whatever's going on with our central nervous system and our stress level. So there's a lot to talk about.
A lot to talk about. And I am sure that most women, and I'm one of them, have never thought about that connection, but seeing visually how everything is located, where they're located, and how just now I'm like clenching myself. I can feel it. And yeah, I need to relax and take a breath.
Right. Yes. Breath is important, very important. And our pelvic floor should move every time we breathe. When I talk about the pressure, our rib cage, our 3 diaphragms, one up at the throat, and then we have the diaphragm at the rib cage, and then we have the pelvic floor. But all 3 of those work together to create and control pressure in our system. So when we're standing up from a chair, when we're lifting something, when we're coughing, when we're sneezing, that's all pressure, which we need and is good. But how do we control it? What are those muscles doing to support the body? And is it controlling in a way that when we cough, is that pressure going more down and pushing into the bladder? And maybe there's some weakness here that can't be controlled. So then we have some leaking that happens. That sphincter can't close.
Yeah.
Or a sneeze, same thing.
Or laugh, right? A lot of women say that when they laugh.
Right. Exactly. Yeah. I can't laugh anymore. I'm going to pee my pants. Right. Like that's like, you know.
There's a reason for that saying.
There's a reason. Yes. That is a thing. And we can change that. Just because you talk to your girlfriend and she says, yeah, that happens to me too. That doesn't mean that it has to. You can do something about that. You can make a change. That's the other thing too, that most women don't maybe know, is that those things are common. The leaking, maybe some issues with like how often you have to go to the bathroom, pain. People will think like, you know, intimacy after a certain age, it's just not going to be, it's painful. It's off the table. I don't need that anymore. Right. Which is sad. Knowing that stuff, although common, it is not necessarily part of normal aging, and it does not have to be what you live with.
Yeah, I think that's the real key from what you've highlighted, some things that I wasn't aware of, the connection. As a speech pathologist, I work a lot with the diaphragm, but I don't go any further than that, down. So trying to get people to relax, and especially the Parkinson's patients need to be able to relax. They need the tension and relaxation, but I don't mean to get off on a tangent here, but point being is that I didn't realize the large connection, and I can relate. There's sometimes where I feel I don't have to go to the bathroom, but I'll feel pressure. I can remember this when I was taking dance classes. Let me know if this is true or not. I would feel pressure and discomfort, and I would get involved in the dance class, and then I would be focusing all of my attention on remembering the steps. And I would walk out of class and I would say, oh my God, when I walked in, I thought maybe I had the start of a UTI or something going on. When I came out of class, because I had relaxed and I changed my focus. Is there any validity to that thinking?
Absolutely. And especially, we get stressed, we get fearful, we are worrying about stuff, maybe going into the class, you're running on high stress out from other stuff. And so you're kind of holding that tension's already there. There's so many people that when I tell them to tune in, feel those bones, front, back, and on those sides, those sit bones. And are they all squeezing together or are they relaxed? Like, can you feel that space, that separation in there?
So you're asking women to actually tighten up and then relax.
Right. Because you said the Parkinson's patients need the tension and the relaxation. We all do. I like to compare it to a trampoline, right? So if we think about the frame of the pelvis being the ring, so the bones are the ring of the trampoline, and then the ligaments that support things are the springs. So the bones can get out of line. This one doesn't really move, but they can get out of line, which you could see would stretch the ligaments, the springs in different directions, and change the tension in the black or the whatever color your trampoline is of the muscles. The muscles are the trampoline. So if one bone is out of alignment, it's going to change the tension and create a little bit more tension in one space, which is going to help it and make it not function as well. If you've ever jumped on the trampoline, a couple springs are broken and it gives a whole lot and you don't quite get that rebound that you should get, or one side kind of gives and the other side doesn't, that is that same kind of picture I think about in the pelvic floor. Or if you've jumped on the trampoline that's like brand new and it's super tight and it has no give to it, that can help with the pelvic floor tension too, is that it's very tight and it's holding. And then we think about the pressure of a cough, a sneeze, the laugh. And when it comes down, there's no give for it to kind of rebound and send that pressure back up. Then that's where we can see issues with leaking. It doesn't always mean leaking. Leaking can be both things. It can be weakness, that we don't have enough strength to close off the sphincter and the urethra. And it could also be that there's so much tension there that it's not having the ability to rebound and recover from that pressure that we put on. Oh. So it can be both things. If you think about when something is fearful, or a mammal, we think about the tail between the legs, right? When something's fearful. And so a lot of times, like, your natural response is to tuck that tailbone, which, remember, connects to those pelvic floor muscles. So we're tucking, we're holding that under. And so then what we'll also see commonly is that this back aspect is very tight and it's sort of pulling the front aspect. So that's overstretched. And that is the space where we need to have that mobility in order to close off the urethra and prevent the urine from leaking. So if there's too much tension back here, this part is overstretched and can't function as well. You can have both things. So, you know, I get bothered sometimes when people, whether it's a medical professional or it's a social media, saying, I'm peeing my pants now. I'm over 60. I'm going to pee my pants. That's what happens. They're like, just do some Kegels. But sometimes the Kegels aren't all we need. Or we're doing Kegels, but people are really squeezing their glutes and doing this. Right. And if I'm truly doing a Kegel, you can't tell I'm doing anything.
Yeah. So as you're talking, I'm squeezing those back muscles and squeezing the Kegel muscles. And yes, I can see the difference.
So I often tell people to, like, kind of visualize the bones and think about those four bones coming together and then kind of lifting up. Like, you know, the claw at the arcade?
Arcade.
And it closes those bones. And so we close in tailbone closer to pubic bone, hip bones closer together. They all come together and then we lift up. That's like
That's a great visual. That's an absolutely great visual, is that claw coming together.
Yeah. And I find sometimes the bones are easier to tune into because we don't, you know, I can see my bicep. I know when it's flexing. I know when something's happening there, right? But I can't see these muscles. But I can put my hands on the bones and I can feel the bones. You can
feel the bone movement or the lack of the bone movement.
Sometimes people just can't find that. You know, we can have sort of I almost refer to it like a black box in the pelvis. Like, it's like we just sort of shut off to it. We don't know what's happening down there. So I'll tell people to do some humming. And the humming, if you do more of a lower tone hum, you'll feel kind of an opening and a relaxation in those muscles, versus if you do a higher pitched high tone, you'll feel everything kind of tighten up.
Interesting.
And so you don't necessarily have to, because some people, they get flustered by trying to visualize and find all the things. And so I'm like, just hum, do a real and you'll feel like a deeper lower relaxation, versus when you go up real high, you'll feel everything kind of wake up there for you. I feel like that's going to be a nice trick.
I wasn't aware of that. Thank you for sharing that. I'm sure that's going to be helpful for many women. You know, the important question today, why is this conversation even more important for women over 50 or 60? And I think you've been answering it kind of along the way here, but would you agree with the statement that I think it's misinformation, and you touched on it just like a few minutes ago, was the fact that women are told that's just the way it is?
Right. Yes. I think knowing that, again, with that hormone change as we age, one of the things that, like, breaks my heart is that people think it's very common and normal for intimacy to be painful. And that as we age, well, it hurts We just don't really do that anymore. And that doesn't have to be the case. We can address that really with the vaginal estrogen is a huge piece of helping those tissues. Those tissues are fed by estrogen. We actually will see when we look at the vulva space, we'll see the labia minora. So you have the labia majora on the outside, labia minora on the inside, and then it opens up to vaginal, to the introitus, to the vagina. And what we'll see is as we age, without adding in that topical or vaginal estrogen, we will see that labia minora actually like reabsorb. They just kind of disappear. And so, a lot of us don't necessarily look and examine our vulvar space, although I do recommend it. You've been in a relationship for a long time, your partner might not even notice the changes or the differences, but it does really change. It will start to reabsorb without that estrogen. So adding in the vaginal estrogen, which as you were saying, like some of the fear around using the hormones, right? And there was a study done, the WHO, the World Health Organization, they did this study and it was in, I believe, 2001. But the results basically, when they read it and they looked at it, they said using hormone therapy increased the risk of stroke and breast cancer and blood clots, right? So everybody like freaked out. But the authors themselves actually came back and said, we didn't really interpret that data right. Like it was really a poor study, the way it's structured and the way it was interpreted, what really wasn't accurate. And so now, 20 years later, we're starting to show the research that says, no, like vaginal estrogen, hormone therapy, systemic estrogen is extremely protective for the brain, for the bones, for the heart, and for these vaginal tissues, these vulvar tissues. So and up until, I think it was October last year, they just removed the black box labeling on the vaginal estrogen. So even though we were, right? It's crazy. Even though we were starting to say that research was wrong, hormones are safe, women might go to the doctor, actually get the prescription, but then they get this box and they come home and there's this black box label on there that says, this may cause cancer, this may cause stroke. And you're like, I don't know. And then they wouldn't use the product. But that box is gone because it was inaccurate. And it just took a long time and a lot of people like arguing and fighting for it to be removed. But now that label's gone. And so it's really cool to see there's actually like a shortage on some of the estrogen patches right now because so many women are like, wait, give me the hormones. Like, let me feel better.
I'm one of them. I am after my conversation with you, Dr. Dani. And that's why I really wanted you to come on to this show because this whole conversation, it just goes so well in pillar number 3, which is mental health and cognitive function. And after our conversation, I mean, you opened my eyes to the fact, as I said in the opening, I was diagnosed with osteoporosis and my dad has Alzheimer's. And I want to share a story with you. It was about 2009. I had gone for my annual exam and my gynecologist said to me that she wanted to try hormone replacement therapy. But at the time, they were using an antidepressant, an off-label use of an antidepressant that they said had great positive results for women who didn't want to do the hormone replacement therapy. So I left her office that day with a prescription. I went for the hormone replacement only because I just, through ignorance, I just don't know a lot about antidepressants. And I felt as though I want to use the medication that's prescribed for the symptoms. I don't want to use something that may get me some positive results. So I remember driving, I was in Princeton, New Jersey, driving down Route 1, and I'm like, oh my God, Cindy, you just opted for the medication that could potentially give you cancer. And I even forgot until you just said, I even forgot about the blood clots. And I think that scared me the most because the blood clot, oh my God, potential stroke. And I remember getting into my garage and calling her office back and said, no, the antidepressants, I changed my mind. I'm not going to put myself at risk. I did go on. I didn't do well. I mean, chances are if you tell yourself you're not going to do well, you're not going to do well. Well, this in my mind. So guess what? I had a reaction to the point that I needed medical attention. I went to those details. But the bottom line is that we just dropped it. And I never did the HTR. I resumed normal life with my hot flashes and my other symptoms, and that was the end of that. And Dr. Dani, I recently read that there are a lot of gynecologists out there that aren't aware that this label has been removed. I do want to go back, talk to my doctor because I do have full-blown osteoporosis in my neck, spine, and hips. My dad had the Alzheimer's. So
Right.
I'm feeling like, oh my gosh, am I not doing something that I should be doing? I'm preaching about how we need to do all these things for cognitive and mental well-being. I mean,
Right.
what's your thoughts on that?
Absolutely. It's unfortunate. I remember from PT school, and that was, 20 years ago, but them talking about the fact that like research takes about 17 years to get into actual practice, right? Now that was 20 years ago. Hopefully it's a little bit sooner. Because we have to change physicians coming out of school, you have to change what you're teaching them for them to come out and to practice. For many years, everybody was fearful of hormone therapy. Although we hand out birth control pills to our teenagers like it's candy, the levels of, especially 20 years ago, the levels of hormone that were in some of the birth control pills was significantly higher than the level of hormone that is in like the transdermal patches that you can get now. It's very small doses compared to what we give as a birth control pill. These physicians, it's not their fault.
Yeah.
They didn't learn it in school. And then they got out and they were working with, as a resident, with physicians who were under the belief that hormones were dangerous and cause stroke and cause breast cancer. And it's like this rhetoric is very slow to change. Unless your physician is staying up to date on the research, which is really hard to do. I don't want to get into the entire broken healthcare system, but when you get 10 minutes with a patient and you're seeing 30 to 40 patients in a day, when you're reading the research and getting that information to, to know that they have removed the black box labeling. It's been about 7-8 months, but that's relatively new in the grand scheme of things. Even the pharmacists will question, well, why are you getting an estrogen patch and topical or vaginal estrogen? Why are you getting two hormones? And it's like, yes, but they work in different ways. The transdermal patch is more of a systemic, so that's going to help with the brain, the heart, and the bone health. And then the vaginal estrogen is really more for the vaginal tissues. And it doesn't have a systemic effect. So even my moms that are nursing, when you're nursing, your estrogen level is lower and you're almost in this like menopausal type state. So a lot of times postpartum, women will experience a lot of the vaginal dryness, the burning, the UTI kind of feelings. And that is that hormone deprivation. And using vaginal estrogen during that time can be really helpful to mitigate those symptoms and to feel better. And it doesn't affect the milk supply because it's not systemic. So there's research to show that the vaginal estrogen is safe for pretty much everyone, whether you are still menstruating, you're not menstruating, it's been 10 years. But as long there's one type of specific uterine cancer that becomes we need to talk about this kind of situation. Otherwise, pretty much good to go. It can help with some of the urgency and frequency that we see sometimes as we age. There is no such thing as a small bladder. Remember we had that little, right? So we don't.
We're busting that myth today, isn't that right?
Right, exactly. Vaginal estrogen can help to decrease some of that tissue irritation, which can help with that UTI kind of feeling. And then also with the intimacy pain. We talk about how as we're aging, that hormone level drops, we don't have as much moisture in those tissues. The tissues become more frail, right? And what can happen sometimes is we are using a lubrication that maybe isn't the best for our tissue. Some of the all the lubes are over the counter, but some of the more common ones that we think of, the Astroglide, the KY, that have been commercialized that we've kind of had for the last 50 years. The osmolality in those is like 3,000 to 6,000. The osmolality.
Can you explain what the osmolality is?
Yeah, so like the pH, the acidity of it, right? And the vaginal tissues, it's 300. So we think about we're putting something that is so much more into these poor tissues that are already like
that are pretty fragile to begin with, right?
They're already fragile, right? Like they're sensitive. I love Uberlube is one that is like around 300. Good Clean Love is another one. I can send you like a list.
If you send me a list, I will post it in the show notes.
Perfect.
That'll be great. Great resource. Thank you.
Excellent. So there's so many other options. It's better for the tissue health, but it feels better too. I'll have women that they'll be like, we use lube, like everyone should be using lube as far as I'm concerned. Lube, yay. Yeah, but then
From a
afterwards,
layperson's point of view.
but then like afterwards, they're like, but you know, then I have it's kind of burny and stingy and that kind of stuff. I'm like, yeah, because if you're using the Astroglide or the KY, yeesh, that's
It,
like putting salt on a wound kind of thing. So the estrogen helps with that. The different kind of lubes, going back to that intimacy idea and making that more comfortable. And if you know, if you're truly, for reasons you discuss with your physician, and the hormones are really not the thing for you, now we're seeing more and more come out what we call like a vulvovaginal moisturizer. And I always compare it as like the eye cream that you put on your eyes, right? Like we know this is sensitive tissue and we put separate cream on there for all the, you know, all the fancy things, right? The vulvar tissue, same thing. So they make these vulvovaginal moisturizers. Kindra's one that I really like. There's another one, Julva. It has DHEA in it, which can help to kind of plump those tissues a little bit, which can also help with the pain with the intimacy and some of the incontinence. We're plumping things back up. We're giving them more life, more ability to function in the way they're supposed to. So those things can be super helpful. And I like to tell people with the vaginal estrogen, it comes with an applicator, which I don't love because it's tough to clean. And really, we want that cream on these vulvar tissues. The application, we use the applicator in more of a suppository. You're putting it up inside the vagina.
It bypasses those tissues.
Bypasses those important tissues, right? So I tell people to use the applicator to put the dosage on your finger. So you get like a visual of how much you're going to use every day. And then you spread that, separate the labia, spread it through the labia, spread it inside labia around. If you're having those burny UTI symptoms, spread it around the urethral area. If you're having issues at the other ends, like the hemorrhoids, the fissures, that kind of stuff, we can spread the estrogen back there, which can also be super helpful. Again, the kind of a tangent, but the hemorrhoids a lot of times is a poor pressure management situation that we're straining a lot, or we don't know how to lengthen and release that pelvic floor to allow the stool to pass. So we're tightening when we're supposed to be relaxed. And that can make more pressure down there and contribute to the hemorrhoids.
No idea that cream could be helpful, you know, used that way.
Yep. Yeah. So it's super. And then, you know, I do remind my clients to make sure that you have nothing else on your fingers before you put the vaginal estrogen on. Because if you put your eye cream on first, then you put that on, if there's some residue there that maybe doesn't go well with the vaginal tissues, you're cross-contaminating in a sense. I do it as soon as I get out of the shower, put my stuff on, wash my hands, and then move on. I keep it like right in the bathroom. And after that first 2 weeks, and it's usually just twice a week for the vaginal estrogen, it is normal to have a little bit of like stingy burniness for the first couple applications, because it's like that tissue's so estrogen deprived and dry. It's like if you have a bad sunburn and when you first put the
chapped lips
and you first put it on, it kind of stings, but then you're like, afterwards. So that is a normal thing too. I like to tell people, because they'll get scared and then they're like, well, maybe I'll just do it like once in a while. But then we don't really get over that hump of getting that tissue rehydrated and comfortable with it.
That's a good point, because conversations I have with girlfriends is, oh my God, it burns. I'm going to, you know, cut down. Like they're now managing the dosage when they really need to comply with that first full week of doing it every day, and then cutting back to that twice a week, doing it as prescribed.
They don't do a great job of communicating that, pharmacy or from the
many times they don't.
Exactly. Yeah. Finding a provider that has understanding of the hormones and is willing to listen, because that's the other thing too, as our hormones change and shift, a lot of the symptoms that we get, like the brain fog, the difficulty finding a word, the insomnia, everybody I feel like knows like night sweats, hot flashes. Like that's what we think of as like perimenopause, menopause, right? Like, so, and menopause truly is like, it's the one day that it has been 12 months that you have not menstruated. Now that's menopause. And then afterwards we're like postmenopausal. So it's very funny to me that like we always talk about like, well, I'm in menopause. And it's like, no, menopause really is like one day. You're either like perimenopause, you're building up to that like 1 year of no menstruation. And then that day that you have had 12 months of no menstruation, that's menopause. And then you're postmenopausal. Then you haven't had a period for more than 12 months and you're you're in that other range.
Thank you for that great clarification, because I hear it all the time.
All the time.
I'm in menopause. It seems like I have friends that have probably been in menopause, according to them, about 5 years.
Right. Yeah, exactly. And so the average onset of menopause, that day the period stops, is 51 in this country, right?
Okay.
But perimenopause, that time frame up to it, can start 5 to 10 years before that. We're looking like 41, sometimes earlier. That's the average of 51, right? So there are
Right.
people that are in menopause at 45. So that means at 35, they could have started with some of the symptoms. And there isn't great blood work, lab work that we do to test the estrogen, the progesterone, like these hormone levels. They really vary. So it's not always the most accurate. We test it once and we're like, well, these numbers are good. Well, they might have been good that day, but 3 days before they were really in the toilet. And the one person I always follow, she's a urologist. Her name is Dr. Rachel Rubin.
And I'll tell you why. I didn't know Dr. Rubin before we had our conversation.
She's awesome. Her thing is, what are you afraid of? What are we afraid of with letting people prescribing the hormones appropriately and having people try it, right? So we're not injecting you with something that stays in your system for a month. It's a patch. If you do the estrogen, generally it's a patch or it's oral, right? For estrogen, progesterone is generally oral. If you have a uterus and you're still menstruating, you really need to have the progesterone with the estrogen. I always compare them to the estrogen is kind of like the fertilizer for your lawn. So it's going to help the lining of the uterus to thicken. And then the progesterone is like the lawnmower. So it's going to keep things at a good level. So we don't want to, if we're still menstruating, we need to have both. And sometimes to start out, we maybe just need the progesterone early on with some of the symptoms. We maybe, if the sleep's being disrupted, right, that kind of stuff, sometimes the progesterone can be helpful with that. But there's so many things that we are learning really are signs of that hormone shift and that hormone change that can be improved. And we don't have to just suffer along with not feeling at our best.
Right.
There's a lot we can do. And then finding, if you talk to your provider and they totally dismiss it and they say, my mom has had breast cancer and ovarian cancer and, strongest woman, she's doing great and survived and all the things.
Glad to hear.
Yeah, even with that family history, and like 2 of her sisters have breast cancer and stuff, I'm fine to have estrogen and progesterone and vaginal estrogen, and it's like.
Because you're educated. That's the difference.
Right. And you really have to be able to advocate for yourself and get the information. Amazing different podcasts and books to really learn and educate and to be comfortable to know that if your physician doesn't feel comfortable, isn't educated on this topic, you have options. You could bring resources to them and try again. Or there's a lot of other providers and maybe it's that you need to work with a different provider for that scenario. But make sure that before they're telling you no, that they really understand the newer research that's out there and they're telling you that as an informed, well-educated physician and not somebody preaching out of fear and the fear of what might happen.
One thing that I found very interesting that you shared with me with all the research that you've done and some of the books that you've read.
Yeah.
Dr. Rubin, she is a urologist, and I have listened to some of her stuff since, you and I spoke about it, and I never knew that gynecologists and are not trained in some of the things. I've been to a urologist for UTIs, but I always go to my gynecologist has now, handled my UTIs now that I'm postmenopausal. And I guess my question is how do we know she's prescribed the vaginal suppository for the hormones? She knows about my osteoporosis. She's the one who did the bone density test. And she saw 3 years in a row getting worse in spite of the fact that I'm lifting heavier weights than I've ever lifted before in my life. Should I be looking at the urologist? Because from what Dr. Rubin said, I'd love to be going to her, honestly.
Right? I know.
So,
well, and I gotta say, she's awesome in the sense that, she's going on a lot of different podcasts. She's educating the public, but she also is offering courses to physicians to educate them on how to write these prescriptions.
I heard that, yes.
Literally, they just don't know. Again, it's not their own fault. They're not, they just don't know. So there's opportunities out there for them, a simple, easy, I think her course is like 4 hours or something. Like, and it's like, she literally gives like examples of how to write the prescription, especially for the vaginal estrogen. It's very kind of basic. With the hormone estrogen and the progesterone, physicians that were doing, or providers who were doing like a testosterone implant, because testosterone is the other one, which we haven't mentioned, which for some reason we decided that like testosterone's a male hormone and estrogen's female, but both parties have both hormones. Men have estrogen, women have testosterone. Like, we do have it at various levels, but
Right.
the testosterone is one that they can check, and that one stays pretty stable. That one doesn't fluctuate as much with your cycles, but they were doing pellet implants for the testosterone, which was a little bit more semi-permanent. If you put the estrogen patch on, you don't like how it makes you feel, you take the estrogen patch off, and it's out of your system. If you don't like, you take the progesterone, they start you on whatever dosage, and you don't like how it makes you feel, they can adjust the dosage. There's lots of variability, but Dr. Rubin talks about it being like a buffet of options, and knowing that you have these options and what works best for you individually. Yes, the urologists are the ones that are more trained on sexual function, the urinary system, and the hormones. A lot of times they have more training than the gynecologist. Now, depending on where the gynecologist has focused, or I do have more OBs that now are in midwives that are prescribing the vaginal estrogen for the postpartum women. The message, it is getting out there.
Yeah.
I think if you get an immediate dismissal from your provider without even a conversation, if they just tell you it'll increase your risk for breast cancer and stroke, that's like a red flag. Tell me more. Can you give me more information? Is that true for me? Can you tell me why that's true for me? Is that the most recent information? You can kind of play it how you want to, right? Do you want to be adversary and like, well, this is what I heard? Or do you want to kind of give them the opportunity to maybe say, this isn't my area of expertise, but
Right.
maybe we can find you somebody who is more of an expert on this. The other thing I would say is that there's always people looking to take advantage of, so there are some very bougie kind of things that are coming out, a menopause specialist and charging insane amounts of money to test and guide and do all these things. And, there are options. I mean, if you prefer, you need that one-to-one and very intimate kind of thing, and you feel like that's what you get, great. But I think sometimes it can feel like, well, I can't do that, so then I got no option. There's a great online health, which is what I actually went through, MIDI Health, MIDI Health.com. And it's online, it's nurse practitioners, it's virtual. They are really hormone experts, perimenopause, menopause. That's their main focus in women's health. I think just finding that provider that you can have a conversation with and can give you options of what's truly best for you and what's going on with you. Yeah.
That's great advice. We can add that as a show notes. Are there any like early signs that a woman should not ignore, should not push it off to this just comes with old age?
Right. Yes. I definitely would say pain with intimacy. That's a sign that there's something changing with those tissues. Changes in your bowels. So in your bowels and in your bladder. Right? So if you're running to the bathroom more frequently, if you're having more UTIs, Dr. Rubin, my fave, she talks about, she's doing some research right now, and it's bonkers to think about it. A lot of people, as you probably know from like your parents and stuff, like as people age and they get UTIs, a lot of times we see more and more UTIs, especially in women. And a lot of times that first sign of the UTI is more like a confusion or like a loss of balance. It's neurological cognitive changes before they really complain or notice the usual symptoms, the burning, that kind of stuff. But then we see more falls, right? And then we're not having any hormone therapy, so our bones are more brittle. So we fall, we break a hip, and it's like, phew, this like downward terrible slide. So her discussion is like, because there's basically vaginal estrogen is good for every woman. If we're using the vaginal estrogen and that is maybe preventing the UTIs, then it's preventing this like cognitive neurological change, the fall, the fracture, the whole thing. Like she, and let's be honest, a lot of things come back to money in our culture, in our society. And so we think about the hospitalization for the fall, the surgery, all of those things. we could backtrack all of that for a $13 tube of estrogen every month.
Yeah.
So, I think seeing those changes, I would be like, okay, I want to do something about this. I want to be proactive. We can notice changes. This is a piece we didn't necessarily talk about yet, but the constipation piece, we talked a little bit about like the hemorrhoids can happen. I find a lot of times for women, we don't necessarily give ourselves the time to have a bowel movement. Then, heaven forbid, we don't want to have a bowel movement in public, at work,
Right.
or anywhere like that. So when we get the urge, we just sort of stifle it. We're not going to go. We hold it. But then what happens is that stool sits in the rectum and it dries out more and it gets firmer and harder to pass. And so then when we finally get home and we're able to have that bowel movement, now it's a little larger, it's a little firmer, it's harder to pass. It creates more pressure, more pulling, more strain on that anal area. And so it can create more damage. And then we now have pain when we have the bowel movement, or we have to strain a whole lot, again, creating that pressure.
Right.
And that's going to feed the brain by telling the brain that like, ooh, bowel movements are not good. They hurt. We're going to avoid those. And so then it's like we sort of maybe don't go as often because we feel like, oh, that really hurts. I don't really want to go.
Right.
And you avoid what hurts. So now that cycle continues. And we end up getting more and more constipated, and it becomes more of an issue. So I love to prunes are your best friend. I'm like, eat your prunes. They help to get things moving. Drink your water, eat your prunes. And really, we should be having a bowel movement every day. Medical definition of constipation is that as long as you're having a bowel movement once every 3 days, you're not constipated, quote unquote.
I couldn't get through day 2.
Right? Like, and it's amazing. Like, and I mean, I see it in my girlfriends all the time. They're like, oh, I haven't pooped in a couple of days. My belly's kind of full. My belly's bloated. My pants don't fit. Like those kind of things. And it's like, ooh, I'm like, no, that's not good. We need to go every day. Like you think about like, back when you had the babies and you think about, you're like, you're so focused on, did they poop? Right?
Poop,
like,
right.
Did they poop?
How much did they sleep and did they poop?
What color was the poop? We like really cared about poop when we were little, and then we get older and we like kind of, but then it does come back around. I remember my grandma talking all the time about like,
my mother and her prunes. Yeah,
yes,
truly.
Exactly. I say, I'm like, I don't know, I'm like my grandma now. I have my tea and my prunes every night, and life is good. Things move along.
Yeah, no, it's important. It is important. That's for sure.
Well, and we can even relate it to the constipation. I had the organs out of here when I was talking before, but if we put my bladder fell on the floor, sorry.
Your bladder's on the floor. Oh boy.
Bladder fell on the floor. That does happen. That's prolapse. The organs all fit inside that pelvic cavity. There's not a lot of space. So if that rectum is full of stool, it's pushing on everything else. And the bladder doesn't like to be pushed around. So when it gets irritated, it's going to the bathroom more frequently, creating that urgency, maybe having some leakage. So that really does tie together. Right. And how is everything functioning? How often you go in the bathroom? Tell me what's happening. Like I'm teaching her like a colon massage to help things move, because most of the time those people are constipated. Like I would say 70, 80% of the time there's constipation playing a role there. So we're talking about good toileting mechanics, breath, making sure that we are able to relax and lengthen that pelvic floor to allow the stool to pass, and working through all of those things. And then we're talking about that pressure management. And if it's a leak whenever we cough, when we sneeze, we're looking at how are we lining up those diaphragms. So this might be easier to see standing, but like if we are standing and we're back here a whole bunch, our abdominal wall is getting that pressure and we're kind of sitting. And if you think about it, this is like where we go, we hold a baby, right? And then if I wasn't holding a baby, I'd look ridiculous. But a lot of us are still sort of standing just a little bit that way. Shoulders are beyond the hips, belly's protruding out, and that pressure is going down on the front part of the pelvic floor. So if I'm here and I cough or I sneeze, the pressure is more down. So the first tip I'll tell them is take that rib cage, stack it up on top of the pelvis. So now everything's in a better alignment, so that now when I cough, there's that forward, kind of like a posterior tilt, and we're contracting those muscles here to bring everything supported, right? So the same thing with the sneeze. A lot of us kind of do like that number, where we're sneezing and laughing too much, right? But I tell people to brace a little bit on the chair and push down. That'll help to create that abdominal pressure, and that you can do the sneeze, the cough, the laugh that way. Or if you're already seated, then we want to think about making sure that we kind of push down on the legs and create that pressure and change it that way. And then I'm going to look at the muscle tension. So I will generally I don't have to, not everybody likes this, but I will do an internal evaluation so I can feel the muscles inside the vagina to see through the wall of the vagina. I can feel that ring of muscles to tell, is there more tension? Remember how we talked about the trampoline?
Right.
Like, are you holding a lot of tension on that right side or on that back aspect that is limiting the ability of those front muscles to really do their job? Getting people to tune in and find where that tension is, and having my finger inside to be able to put pressure on that space and say, and usually they're like, ooh, yeah, right there. Like that, I can feel that feels different than over here. And so you're creating that brain connection to these muscles that we can't really see, and be like, okay, I want you to like breathe into that space, let that relax. And can you feel when it's soft? And then I'll have them do a couple pelvic floor contractions, Kegels, so that I can see what's happening when you do that. Are both sides contracting equally? I'm going to check bony alignment and make sure that frame is equally moving and that everything is lined up well, so that it has a good support system to work off of.
Oh, that's so interesting. Yeah, it's awesome that you do that type of work.
Yeah. And a lot of people are scared to go to pelvic PT. They're like, what am I going to do there? Like, and every person that came, they won't even tell me they had that fear to start. But when they leave, they're like, I was so scared to come in here, but that was awesome. There's so much to learn. I didn't learn this in PT school. I learned it afterwards. We didn't even talk about the pelvic floor. Yeah, there's some muscles down there that kind of hold things in place. And that's what most of your providers have gotten too. So even with the OBs, like I've spoken with the OBs and stuff, they don't get the same training and education on how to really examine the more superficial muscles of the pelvic floor, the deeper muscles. It really isn't there. So, they're not always able to help you as much as they might want to. But they're, I feel like we're learning more, that they're like, okay, go see the pelvic, the PT, the OT, like, and go get that care.
Right.
So.
Exactly. And Dr. Rubin, even in one of her talks, brings that out, is the fact that the urologists are more trained in that area, and it's just the way it is. But as I wouldn't think of going, well, I have, because for UTIs, I have gone to a urologist, but it was more really wanting to do a dilation, doing instrumental, and then based on that, doing the dilation.
Right. And I think that's one of the other, we hadn't mentioned before, but interstitial cystitis, IC, painful bladder syndrome, is another one that is often common in 55, 60, 70, and thinking that like there's really nothing to be done. But I mean, I saw a woman recently, she's 58, and she's been like dealing with it forever. And we did a lot of like abdominal release work. Again, that idea that when we're in pain, when we're uncomfortable, we're holding, we're tensing all of this muscle all the time. And so then that tension, that fascial tension, is also going to pull on the organs. And the bladder's like picky. Bladder like wants to be like calm, chill, have its space, not be pulled off to one side or the other. And when it's not happy, its way of letting you know that is by changing those bladder symptoms. So it's a peeing, it's the pain, it's the burning, it's those things. So, being able to, I think even with the IC and some of these painful bladder symptoms, or the small bladder idea, right? That like knowing that like those, again, may be common, but they're not normal, and finding somebody that can help you through that, and knowing that it's not just the medication that can help. I think sometimes we forget about the whole package. And we talked about like the stress level, right? Like, so, I'm working with people on calming that nervous system? And can we do some breathing? Like, I know you're a big fan of the breathing exercises
Mhm.
too, right? And
Yes,
can we do some
absolutely.
breathing
Yes.
and get that nervous system to calm down? Again, that ties in with the constipation, because if we're up here, the last thing our body physiologically is thinking about is having a bowel movement. Now, sometimes you
Yeah.
may have this stress diarrhea response, right? Some people get that.
That, yeah.
Majority of the time, it kind of stifles the bowels. So getting that nervous system to have calm so that we can have the bowel movement, which can keep everything functioning better.
Exactly. Yeah,
Yeah,
eliminating the stresses, maybe that pulling, and because it's so tight.
exactly.
And it's really interesting. So what are some recommendations for other things that women can do along the lines of maybe an exercise or uh,
Sure.
a position for relieving some pressure?
Absolutely. So one of my favorites is called Legs Up the Wall. And they do it a lot of times in yoga classes, but you can do this in your bed too. You're going to bring your bottom all the way up to like the headboard or the wall. If you're sitting on the floor, if you're on the floor, you're going to slide your bottom all the way in, and then you're going to put your legs up against it. So I was joking with Cindy earlier, like really the
Right.
visualization, your legs are up straight on the
Right.
wall, your butt is against the wall or the headboard, and you're just kind of settling there. You can put a pillow or blanket underneath your pelvis if you want to kind of elevate it a little bit. But the idea, you can go on this different ways, but when we're upright and we're walking around for the day and all those things, all of our blood flow, everything's kind of going down. In the yogic world, our energy is sort of always being down, down, down. So by flipping that upside down and putting our legs over our head and resting in that way, we're now kind of reversing that blood flow, reversing that lymphatic fluid, reversing that energy, that everything's kind of moving back up in the system. It can take a lot of pressure off the pelvic organ if we're dealing with prolapse symptoms. So it can kind of reset that a little bit. That strain on the pelvic floor, that
Mhm.
trampoline, those springs, everything being stretched heavy, we're now setting it back and letting it rest. And then I love to have people hang out in that position and then, kind of train your parasympathetic nervous system a little bit,
System.
right? So we're experts at being in like sympathetic fight or flight. Like we're all just like,
Exactly.
right?
Right.
But like being comfortable just being still. So when your legs up the wall there, we're not scrolling on our phone. We're just laying there. We're breathing. If we feel like we maybe like need to re-energize a little bit, I recommend palms up. So we're kind of getting energy. If we are feeling more frazzled and we need to be grounded, palms down, and we're kind of getting that groundedness from the floor, from the bed. That's
Okay,
in.
great. I love
Uh,
that. Thumbs up, thumbs down. Got it.
yeah, we need to ground. We need a little more energy. And then in that, so you can just hang there for like, I recommend minimum 2 minutes, but I really like closer 5 to 10 minutes. That can be a great one to do before bed to a couple reasons. So it helps to lower blood pressure, helps to put you more in that parasympathetic state, helps that fluid to move out. So calming the system so that you can fall into that deeper sleep. And we know sleep's super important for the brain and all the systems. But then it also has a function of getting that fluid out. So you can even pump your feet a few times while you're up there to kind of flush that fluid down the legs and into the pelvic area and kind of out, so into the lymphatic drainage, right? And then it can make it easier that if you kind of do that and then maybe go to the bathroom one more time, can give you that longer stretch during the night. Because with
Nice.
that nighttime urination, really our systems should be able to hold the urine for 6 to 8 hours during that sleep period. So maybe once a night, but we should get some nights of uninterrupted sleep. If we're up 2, 3 times a night, that's
That's
terrible
that's a
for,
good sign, I would say. Would you
yes,
agree?
exactly. Exactly. You start getting that disrupted sleep. That's a sign that something's off in the system. So that legs up the wall, I love that. And then I love the physiological sigh. So you're doing 2 inhales and a
Okay.
longer exhale. So we're going to sniff in through our nose. We want to do 3 rounds. So we get a nice inhale and then a little bit more. And good. One more time. But that can
I
be a really,
breath work. It's just,
yes,
it is such,
yes,
it is so easy and it accomplishes so much.
so
So,
much. I'm the one that like, I literally just made a story post yesterday or the day before on Instagram where I pulled into the aftercare lot to pick up my kids. I have 4 little ones, or 3 little, oh God. My husband sometimes counts as one, but I only have 3. I have 3 little ones. But I did that like 3 rounds of that physiological sigh before I went to get them, because I knew I had just done the like, finish the work, run home, grab the stuff for the sports, pack the sandwiches, come to grab them to run out to go do the things, right? And so it's like we all have these different stress loads that like whatever phase of life you're in, where you just like, we're up here, we're up here. And I feel like we have to take the time to train that other side, that parasympathetic, that calm. And if we don't train it, we can't expect it to work for us.
Exactly.
You know, it just won't.
It's just so easy. Like you said, when you pulled into the parking lot to pick up your 3 boys, I mean, what did it take you?
2 minutes, maybe?
Yeah.
And that was me talking to recording to the phone, like, and literally looking out the window and seeing the aftercare counselor, like looking, because she knows my car. And I was like, you know, just take that pause, like just that couple minutes can make such a huge difference.
It is so, like, we both believe in the idea of breath work and the benefits that it has for our bodies. And you're talking also about the brain. I get that, but your focus is sometimes a little bit maybe different than my focus, but it just, all it does is it really highlights the fact of it just helps us in so many ways, that if you just take a little bit of time. And honestly, I mean, I just experienced this with my own patients, is that as we get older, we become our breathing is more shallow.
Mm-hmm.
And unless we take the time to really be aware of it, or we at least take these breaks to get some work, oxygen into the different parts of our body, and then also, like you said, to overall relax us, and that is so beneficial for so
Absolutely. And to tie back into the diaphragm and the pelvic health, right? So every time that you take a nice inhale and you feel that pelvic floor relax, and then that exhale and bring that pelvic floor together and press that air back out, you just did a pelvic floor contraction. You did pelvic floor exercise. You don't have to squeeze Kegels. Getting that movement and being aware that those bones are spreading apart, the muscles are lengthening and stretching as you inhale, and then reversing as you exhale. They're kind of recoiling and curling back up, pressuring that air out. You're doing pelvic floor work right there.
I mean, if I polled like 10 of my girlfriends, and I wanted to say golf girlfriends because I experience this a lot on the golf course, is we're on the back 9 and women will say, oh, no, I don't really have to go, but I know that there's only one restroom on the back 9. So I better go now, or else I may not make it to the end. And so I don't get the whole concept of, I know many of us were raised on this. We'd take a road trip with our parents. You'd say, did you go to the bathroom? And we'd say, no, we don't need to. No, go try, one more time before we go, because we're not stopping for another whatever hours. And so it's a concept that I've never been able to relate to, because if I have to go to the bathroom, I have to go to the bathroom. If I don't, I can't.
Mm-hmm. Yeah. Well, and I think
trickle.
Yeah, right. And I think sometimes, and that's the thing that's like, I also like people to know, is that like the urinary system is sort of this constant flow. So people will be like, well, I don't really have to go, but I'm going to go just in case. Right. And they're like, well, urine came out. And I'm like, yeah, urine's kind of always going. So urine's going to always come out unless you're like completely dehydrated, like urine's coming out. Right. So like you said about the kids, like I cue my kids. I mean, I definitely, same thing. It was like, you got to pee before you get in the car. You pee before you leave the house, like every time. Right. And I think there's something to be said with tuning in, giving yourself a minute to check before you leave the house. But if you just peed 30 minutes ago, you most likely do not have to go pee before you leave the house. It's like you're conditioning your brain, your bladder, to think that I'm leaving the house, I have to go to the bathroom. And our bladder is super trainable in good ways and bad ways, right? So normal bladder function, we should empty the bladder 6 to 8 times in a 24-hour period. So in that whole period, right? And so if we're going 10, 12, I mean, I've had women going 19 times a day. That is how often they are running to the bathroom. Every hour.
And that would necessarily increase amounts of volume. I mean,
no, or I had one woman, she was definitely overhydrating, right? Like she was taxing her system too much. But like there should be a balance. It's like your checkbook. There's a balance with how much money goes out, how much money comes in. This fluid out, fluid in. Like I'll have people do a bladder diary with a urine hat on the toilet and really measure how much is coming out and keep track how much fluid's going in. And let's see, are we overtaxing the system? Are we overhydrating the system? Are we coming home, we realize we didn't drink anything all day, so we're chugging 8 ounces, right? We're flooding the system.
Not right now, but I do want to ask you that question, but go ahead. Yeah, remind me that I want to ask the question about flooding the system. Go ahead.
Yes, about flooding the system. So that idea of just going before we leave the house, when we just went, we're now telling the bladder that yes, you need to empty, even though you may only be 25% full. When that signal really should come somewhere, the first one somewhere around 50% full, that's that one where you're like, I could go right now, but like, I don't necessarily need to go right now. We're going to hold it for a minute, right? Up until like 75% full, that signal comes a little stronger to the brain. And it's like, yeah, okay, like we're getting full down here. We should really find the bathroom. And you can usually delay that if you have to. I don't know if Cindy will recall this. Like we used to work together and I was that chronic, and this is healthcare providers and teachers a lot, where we like hold it until the very last minute. And then literally you're like, I am going to pee my pants. I need to go right now. And that's like max capacity. And that's not great either, because we can overstretch the bladder, that then it starts to lose that perception at the 50% when it should be telling you to go. So, there's this sweet spot in there. So, when you're going to leave the house and you're like, I got to go pee, stop and pause, tune in. When did I pee last? Did I just chug 8 ounces of water or something? Maybe you don't have to go. And being like, okay with I'm going to leave and I'm going to not,
kind of eliminating that fear. I think some of it comes from a little bit of fear, like, oh my God, if I don't go now and I'm going to get in the car for an hour, I'm going to be wiggling in my chair and hoping that I can find a decent bathroom to empty my bladder.
Right. So a couple strategies. So these are what I call urge suppression strategies. So when you have that urge, but you can't go, and maybe you're trying to build this tolerance, right? Because it's not going to happen like overnight. You're not going to be like, you know what? I'm not going to go anymore unless I absolutely have to go. And you're going to change all those behaviors. It doesn't work like that. Right. But if we're being like, okay, I'm not going to go right now. I'm going to make it to my girlfriend's house and not go to the bathroom until I get there, if I still have to go. Because I just went and I'm leaving the house. Like I went 20 minutes ago and now I'm leaving the house. I'm driving 45 minutes. I should not have this problem. So you can do heel pumps or toe pumps, right? So you're basically, my feet are my hands right now. My hands are my feet, but you're going up and down on your toes, pumping those legs like you were doing heel raises. You can do it seated or standing, okay? But by making that foot, like you were going on and off the gas pedal, that is working the S1, the same nerve that goes into the bladder. So you're sort of resetting the system or suppressing that urge. You can also do toe curls. You're kind of squeezing your toes and crunching them up. This can be very helpful with like...
I'm doing them as we speak here. I'm doing them over here.
This works great. I do this in the car with my kids or grandkids in the car that are like, I gotta go pee right now. And you're like, I'm in the middle of 287. Like I can't get over, like you gotta hold this for a minute, right? Telling them, pump the feet, curl the toes. Sometimes it's a distraction, right? Which is another technique. So we get the brain thinking about something else other than this full bladder. And then the other one is calming that system, right? Doing a few deep breaths, maybe doing a few pelvic, like we can do about 5 to 6 of those pelvic floor contractions can also help. The muscle inside the bladder that squeezes to empty the bladder, it works reverse of the pelvic floor muscles. So pelvic floor muscles should be relaxed. Then that detrusor muscle will squeeze and urine will come out. So in theory, if we're squeezing and releasing pelvic floor, we're telling the bladder to not squeeze. Does that make sense? They work reverse. So that's the other reason why you should not practice Kegels on the toilet. That is not the place to do your Kegels.
Interesting. Okay.
It can be a test here and there to see, can I stop my flow of urine? That can give you some information on your pelvic floor strength. And can you...
in a safe place. I get that.
In a safe place, right? Can I be midstream and stop peeing and close off pelvic floor? That can give you a test of strength. But we should not regularly practice that on the toilet because they work opposites. So the pelvic floor muscles should be relaxed whenever we're emptying, right? So reversing, by squeezing the pelvic floor, we kind of turn that signal off of the bladder so it's not trying to empty right now. The deep breaths, distraction, start thinking about, like, I don't know, multiplication factors or whatever, like really get your brain
like they
challenged.
say, name 5 things you see,
Yes, exactly.
4, 3, 2, 1,
use some of those cognitive tasks to delay that urination, and then starting to avoid that just in case pee, because again, that's kind of teaching the bladder to empty when it doesn't necessarily need to empty. Or like if you wake up in the middle of the night, and a lot of people do this, they wake up and they're like, oh, I'm awake, I should just go pee now, because otherwise I'm going to wake up in an hour and have to pee. Right? Yeah. Yes. So ignore that. Tell your bladder, your job is to store the urine. We're going back to sleep. Sleep's important. You can store for 6 to 8 hours. I'm going back to sleep. Roll over, try to go back to sleep, right? I'm not asking anybody to hold until they're like super uncomfortable and crying, I'm going to pee my pants kind of thing. But we can work on these little changes that really change how the body functions, so that we don't want to be captive of our bladder. Like, I don't want to have to be like constantly aware of like where the next bathroom is. But a lot of women live that way.
They do.
They really do.
Absolutely do. I know women that have it mapped up, and they, within a 10-mile radius of their house, they know where all the cleanest bathrooms are.
Yeah. Yeah. And again, it's like your bladder gets trained. I always compare it to the dog. The dog, my dog does this. As soon as I touch the food cup, drool starts coming, right? The Pavlov's dog, right? So our bladder is kind of the same way. It's that every time you come home, the first thing you do is drop your keys and run to the bathroom. Now the bladder starts to learn, well, I'm pulling in the driveway. Ooh, I get to go soon. And it's like getting excited. And it's like, it starts to squeeze. Like, it's like, I'm ready to go. And you're like, I'm not in the house yet. Right. So, sometimes literally there was one, they looked at just distracting the brain. So like, change your pattern. Go in. If you always go in the front door, go through the garage door, put your purse down, wash your hands, and then go to the bathroom. Change that pattern, confuse the bladder so it's not so predictable, and that you're going in a state of calmness and control instead of a state of, I'm going to pee my pants.
I can't get my pants undone fast enough.
That's the one, right? I get to the bathroom and I'm like, I can't get my pants on, the pee's coming out. Right? So like, that's, that being in control and working, those are signs too, that like, there's a problem. Again, talk to your girlfriend. They do the same thing. You think it's normal, but it really isn't the way it's supposed to function.
And again, it's because they're getting older.
Right.
This is what happens when you get older. It's just the way it is. And so now I wear a pad. I don't personally, but I wear a pad every day because I can't go out of the house without it. And
unfortunately, a lot of times the providers will kind of tell you the same thing. You'll ask your OB, your doctor, your primary, and they'll be like, well, you're 70 years old. This is what happens when you get old. And I'm like, I'm gonna slap those people and be like, but or it's the opposite. Well, you had a couple babies, like that's what happens, and it doesn't have to be. It really doesn't have to be,
To your point about the fact of not only training our brains, but also the connection, that connection that exists between your central nervous system and being in that state of fight or flight and being so anxious and nervous about something. I could remember so clearly when I trained competitive all-star cheerleaders, and we'd be at nationals and we'd be old. I would have such a sensation that I had to go to the bathroom. I had to go to the bathroom now. And my concern was these arenas were so large. By the time I left the arena to find the bathroom to get back through the crowds, I was going to potentially miss my kids performing. And it was only minutes and 30 seconds. So we would be in the hole and then on the stage, and I'd be in front of the audience and feeling like, oh, I have to go to the bathroom. I would get into the routine. I would watch all, the areas that I was concerned about. Hopefully they did, zero deduction performance, and they'd come off the stage. And like about an hour later, I would realize I never went to the bathroom, and I no longer had the sensation or the urge to go.
Yeah, absolutely. And it's very common. And so working on training that bladder and literally talk to your bladder, tell you it's your job to store this urine. I'm going to have you hold it. You got to do your job. And, like that, there's a piece of that brain connection that is very
so
powerful and real. And you can do the ankle pumps, you can do the toe squeezes. That's like a more motor neuron gonna change that signal. But there's also a huge piece of that cognitive part and being in control of your system and not letting the bladder run the world. It's like the unruly, dog or toddler that's like demanding treats all the time, right? And being able to, no, we're not, I'm changing the rules today. I'm the boss. That's what we do. That's like I do it to my kids all the time. I'm like, oh, sorry guys, new rules today. But I think it's an important thing to share with our children or friends. You only do what you know. You know more, you do better, right? So just like we said, it's not the provider's fault that they don't know about the hormones, right? The parents, if I hadn't done all this pelvic floor training, I would have been making my kids go pee before they leave the house too. Now I'll ask them to pause. And I'm like, okay, guys, we're going to get in the car. We're driving 3 hours. Really don't want to stop. Tune in. Tell me, when did you go to the bathroom last? Does your bladder feel like there might be some pee in there that you need to let out? Or do you think like you're good? And I will trust them with what they say.
That's awesome.
I don't argue with them. Worst case scenario, and I'll tell, but I don't put the fear in them. It's different with the kids. It is. But thinking about that training, and then let's do better for the younger generation and teach them more to listen to their body. I think creating those patterns and teaching the younger generation is huge with how we all function later.
I totally agree with you. So that was so informative. It really was. I know that every listener should get something out of this. For sure, I'm thinking in my mind, so many women that I'm going to let them know about this episode and recommend that they listen to it, because Dr. Dani, you're very thorough. And if there's anything else in closing that you would like to share that women should be doing to take better care of their bodies in this regard, and then also if you could add in your closing final words, whatever they may.
Whatever my words of wisdom, we'll see. Knowing that just because something might be more common, that it is not necessarily normal, and it doesn't have to be your situation.
So key. That's a great one. If you could repeat that one more time, that would be great.
Yes. That what may be common is not necessarily normal and doesn't have to be your reality. It doesn't have to be what's going on for you. So I think looking for the help, getting the information, and knowing that these small changes can make a big difference and really have a huge effect on how your whole body's really working. If I can get around the full 18 on the golf course and not have to be worrying about which bathroom to use, that's awesome. Or I can make the road trip and not have to panic about how many times I might have to stop. Those little changes can make a big difference. And in being comfortable in looking for the healthcare that you really want. I do physical therapy and see people in person in New Jersey, but I also see people virtually. As you see, I have no problem getting up and showing people things on camera. And there's a lot you can, without actually getting my hands on somebody, that I can influence and change, and just finding those people that can help you and get the help.
Yeah, so helpful. Again, in the show notes, Dr. Dani, I will put your contact information. I think they would really benefit from all your knowledge, and helping them comes down to the quality of life.
Absolutely.
And if you can take out that one thing of having to constantly look for the bathroom, or constantly wear a pad every day, or be afraid of wetting yourself, I mean, those are huge concerns, and they weigh heavy on our minds. So if you can take that off your list, that's a relief.
And intimacy can relieve some of those stressors too, knowing that it doesn't have to stop at a certain age because it's painful. There's things to be done to change that. There are a lot of things to change, and to releasing the endorphins and working on that parasympathetic system.
Well, thank you so much for your time today. Again, to women that are listening, if you have a friend, I know that we all do, that could benefit from this, I would ask that you share this episode. And once again, Dr. Dani, I can't thank you enough for taking this time today to present all of your knowledge and recommendations. And I think it's very informative. So I thank you, truly thank you so much.
Yes, thank you for having me. It was fun. I love sharing this stuff. I think it's really important.
I agree. On that note, until next time, ladies, stay curious. This episode is part of our Encore Expert series, and I thank you so much for joining in today. I'd like to send out a heartfelt thanks to Dr. Dani for this important and eye-opening conversation. I have two big takeaways from this episode. Number one, we all deserve to make decisions, especially our medical decisions, based on facts and not fear. And number two, issues related to your pelvic floor health are simply not something you must live with as you age, and you truly do not have to suffer in silence. So I'm hoping that any questions that came up for you today, that you'll be taking them to your healthcare professional to discuss further. I have never met a woman who has not struggled in some way with some type of pelvic floor issue or hormones. So let's help Dr. Dani and Dr. Rubin get the word out by sharing this episode with as many women as possible. To continue the conversation, join us inside the Encore Women's Circle. The link is in the show notes. Be sure to follow this podcast, watch the episodes, and connect with us on social media. Your support keeps this podcast alive, and I truly do appreciate it. Bye for now. Until next time, please remember to stay curious.